Okay, guys, this is Dr. T, and yeah, once again, welcome to Clinical Medicine with Dr. T. Please, if you have not subscribed to my channel, please do that. That's going to help us a lot to grow as a channel and to reach more students and more people out there. So, let's talk about this PMTC protocol. This acronym stands for Prevention of Mother to Child Transmission. Obviously, transmission of HIV. So, prevention of mother to child. Prevention of mother to child transmission does not really start during pregnancy, or doesn't even start after they've delivered. It starts before they get pregnant. So we've got what we call preconceptual. In an ideal situation, okay, let me say, all of us in South Africa are encouraged to know our HIV status. When I say everyone, I mean both men and women. But I'm going to talk more because this protocol, it's centered around the mother and the baby. So I'm going to talk about those a lot. So women are encouraged to know. So I'm going to say women now. I know everyone needs to know their HIV status. But in terms of transmitting, the mother becomes the center. So women are encouraged to know their HIV status before they fall pregnant. When you know your state, let's say women A, let's call her women A. Women A does not know her status. She's HIV unknown. This is women A. But women A is in her reproductive years. Which means women A has got a chance of getting pregnant. She's not menopausal, she's not before puberty, she's in the age where she can actually get pregnant. So women A does not know her status, and then women A decides to go and have her HIV checked. So she does her HIV test, and then two things are possible. Women A can either have a positive test or a negative test. That's women A. And the HIV, if she comes out, she's HIV positive, she's not pregnant at this point, and she's someone who can get pregnant. Now she finds out that she's HIV positive. Now what's going to happen? The healthcare provider is going to start women A on ART or ARVs as they are commonly known, antiretroviral therapy or antiretrovirals. So the day women A test and then she finds out that she's positive, she's going to be started on treatment. And I don't want to make this complicated, but the only time women A would not be started on treatment is if there are contraindications or there are things that are preventing women A from being started. But this ART should be same day. And guys, this is one of the protocols that when I look at my heart just melts. Like, I become so happy because there's a lot of effort that was put on this protocol. There's a lot of research that was done. I mean, if you remember, a couple of years back, when you tested positive, regardless of whether you are a woman or not, you were not started on treatment the same day. Blood had to be taken, and you had to go for classes where you were taught about the HIV, the treatment, the complications, and all of those things, and how to add higher. So you had to go and do counseling before you were started. And that delayed many people from starting treatment, because some wouldn't come back again. They would be lost in the system and nah. So, and then they would just come back now with meningitis. They would come back with complications of the HIV. So that was the protocol then, but this is one of the improvements that have been done. Same day treatment. So obviously, if there's a contraindication to being started, like they suspect that women A has got TB or whatever, they won't start up until they sort out the TB. But most women, or most women, let's talk about women, will be started on treatment on the same day. The bloods that are going to be taken at this point is going to be the CD4. The CD4 is taken, I don't want to get into details again, just to check if they should be put on prophylaxis, like Bactrim or not, and also if they should be screened for cryptococcal meningitis. So it's things like that. So they take the CD4. And you will remember previously, the viral load had to be taken also on the same day, but it's no longer done like that. Now VL is done at 3 months. At 3 months, the viral load, how much of the virus is in the blood. I'm gonna try and explain, because I want this video, I would like this video to reach people who are not medical as well, so they can understand and also educate other people. Because like I said, at this point in time, there shouldn't be anyone who gives birth to a baby that is HIV positive. And the fact that we've got very few cases of positive babies is because we've got this protocol and it's working so well. So the viral load is only going to be done at 3 months. Ne? So another important thing for women A is that she cannot afford to fall pregnant before her viral load can be known, because that's why she needs to, for that 3 months until she comes back, she needs to be on a reliable contraception. Because you don't want, this is about preventing transmission, guys, to the baby. The thing is this, when woman A comes in, and then this is what we should be doing as doctors. If woman A comes in and then she's positive, we should be like, okay, now that you're positive, we want to ask you, when were you planning to get pregnant? If woman A was planning to get pregnant sooner, we need to counsel her about it and say, look, now that we've just found that you've got the virus in your body and we don't know what your viral load is, it's better that you are on a contraception up until we know your VL, which we can only do at 3 months. So, because the higher the viral load is, the higher the chances of transmitting the virus to the baby. So, remember previously it was like, once you are positive, you cannot be pregnant, but it's no longer the case. That's how it was done in the olden days, that when you are positive, you can't get pregnant. But now, anyone can have a baby, but we are trying to instill this protocol, to follow this protocol as strict as possible. I mean, this protocol, I love it. It leaves no gaps. It looks for people, it screens people, and it's clear what happens if the woman is positive, what should happen if the woman is negative. I mean, it's just there. So, women A, let's say now woman A wants to be pregnant. Now it's time to cancel and say, we don't know your viral load. Let's rather get your viral load and see how suppressed it is, so that we can fall pregnant knowing that your viral load is suppressed. Because falling pregnant while your viral load is high, it increases the chances of transmitting. That's what it's about. So if woman A says, no, I was not planning to get pregnant, it's good, it's nice, but she still needs to be on a contraception again, because you may never know what's going to happen. You may never know. We've had people, patients come in and say, I didn't even know that I was pregnant. No, I wasn't planning to get pregnant. So that kind of a thing, you don't want it to happen while we are busy with this. So that's why it's important that we understand the preconceptual, the thinking around it. This is the thinking around it. So when woman A now comes in 3 months, she does her VL. She comes in a few days, and her VL is, because you want the VL, the things that you want the VL to be, first of all, you want it to be low. And a comfortable low is a low that is less than 400. And it's beautiful if it says undetected. If the VL or if the virus is undetected, undetected. So if you do the VL, it comes back and it says undetected, this lady stands a very good chance of not transmitting the virus to to her baby when she gets pregnant. And you want to keep it there. Yes, she's going to continue with the treatment and follow all the other parts of the protocol to make sure that her baby is not HIV positive when it's born. So this is what you want. A VL that is more than 400 is a problem. More than 1,000 is even worse. That's when we talk about high risk infant, low risk, but we're going to talk about those later on. So you want her to be somewhere here before you can say, okay, you can go and have a baby. So that's preconceptual counseling and all of that. So we say HIV positive says, I want to be pregnant, says, I don't want to be pregnant. Whatever, contraception up until. So this is what we call safe conception, right? It's a concept of safe conception. When you are positive, there's no one who can say you cannot have a baby. There's no one in the world who can say you cannot have a baby. But what matters is safe conception. Are you conceiving at a time when the risk of transmitting the virus to your baby is minimal or is high? That's what it's about. And the determinant of that, number one, is a low viral load. Number two, you have to be according to the World Health Organization staging system, at least you shouldn't be a 3 or a 4, right? And also having a lot of comorbidities and all of that are HIV opportunistic infections can sort of like, because as much as we're trying to prevent transmission to the baby, also the mother also matters, because you don't want the mother that's going to die because of opportunistic infections that are HIV related, right? Yeah, so that's that. I hope you guys, you get that, ne? I hope you get that. Let me just say it again. You are a woman, you are in your reproductive years, you go and do your HIV test, and then you are told the HIV test is positive, you are started on treatment, the CD4 count is done, you are told to come back for a VL in 3 months, and in that 3 months you are you need to be on a reliable contraception, so that we wait for a safe conception period whereby we can say, okay, now you are relatively safe, you can get pregnant now. It would be very disastrous to get pregnant while you've got a viral load that is very high. It would be very disastrous. Okay, let's get to the negative. You are a woman, reproductive years, and you do a HIV test and it's negative. When it's negative, obviously you are not going to be put on any treatment. No treatment is you're going to receive then. But you still need to prevent the infection. How? Minimize the chances of you as the mother getting the infection from someone else, meaning barrier contraception. Remember, in terms of contraception or the contraceptions, the only one that prevents HIV is barrier. The others, especially a condom, the others do not. So barrier contraception. Can we really talk about abstinence here? But let's talk about not having multiple partners. Multiple partners, right? And also prevent other STIs, right? This person, if they stick to one partner who also is HIV negative, and then they continue that kind of a lifestyle, and then she falls pregnant whenever she wants to fall pregnant, her baby will be negative because there is no one who's positive there. The mother is not positive, the father is not positive. So yes, we are going to talk about the issue of a partner who's positive living with a partner who's negative. What drugs are they supposed to be taking? That kind of a thing. Yeah. But at this point, if there is no one who is positive between the two, then we have successfully prevented a transmission from the mother to the child, because there's nothing to transmit. They are negative. You get that? I think it's beautiful. Okay. So this is preconception. And then this person, if the lady gets pregnant, doesn't mean that because they were negative before they got pregnant, they will be negative forever, and we're not going to screen them. We're still going to test them. But let's talk about antenatal now, because that's where they're going to go. Because once they get pregnant, they shift to antenatal. So let's talk about antenatal. So antenatal is for someone now who's pregnant. Unfortunately, we get a lot of our women at the antenatal. We hardly get them at the preconceptual, because many people, they come in when they are already pregnant. Many women, there is this thing in South Africa, this myth that people believe a lot, that the people who are positive are women. No. I mean, they say a lot of women are positive more than men. It's not the case. The thing is this: when women get pregnant, their antenatal care involves, or it includes, HIV testing. That's when most of them are picked up. But men, they only test when they are really, really, really sick, but they've been walking around being positive. Just that for them, in their life, there isn't really a point where they are actually, first of all, their health seeking behavior, men, is very poor. They don't go to the hospital even if they are sick. And because many women, they do get pregnant, and when they get pregnant, they will be tested. Yes, they will be offered the VCT. Even if they feel that I don't want to test, they will still test, because they will be like, if it's for my baby, I might as well do it. Obviously, there's no one who's forcing them to do it, but we always explain that if it happens that you are positive, we just want to have a chance that we can save your baby. We can prevent the transmission to your baby. So most of them, because they are good mothers, they will agree to the test. So that's the thing. That's the thing. A man can walk around being positive and not knowing. They can walk around for years being positive with not knowing, just because they haven't been to a hospital in the past 5 years. But if you're a woman, you're gonna get pregnant twice in that 5 years. It means that you are gonna be tested sort of like twice in that 5 years, if I may put it that way. Okay, it's okay. Let's get to antenatal. So the antenatal part is now someone who's pregnant. So the antenatal starts from the day a woman finds out they are pregnant up until they deliver. That's the antenatal period. So in the antenatal period, HIV testing is offered the first time they present to the clinic or to the healthcare provider. Once they find out that they are pregnant, the next thing should be, let's do the HIV test. So the first visit, the first ANC visit, they should be tested. If they are negative, they should continue to be tested on each and every visit. Every visit, they must be offered a HIV test. Why? I mean, when you get pregnant, at month 1, month 2, month 3, you can be negative, and then later on, you are picked that, oh, actually, the test now is positive. So that's why you must be checked each and every time. Because if, let's say, in the first month, second month, you are negative, and then you never test again, but then the test, but then you end up, let's say first month, second month, you are negative, you go to the third month, fourth month, you are not tested up until you deliver, just because you were negative in the first, second month. So it doesn't, so basically being negative in the first, second, third, fourth does not mean you are gonna remain negative. That's why I'm saying this protocol is very good. It doesn't leave any stone unturned. It doesn't leave anything to slip through. So it's very intense, and I love it so much. So you are gonna, as much as on your first visit, it doesn't matter when you came for your visit. Even if you can come we encourage people to go to the clinic as soon as they find out that they are pregnant. As soon as they find out. I know most of our women, they want to start to see a big abdomen growing for them to start going. It's not right, guys. We are supposed to go when the day you find out that you are pregnant. I mean, if you miss your period, you should be worried as a woman. Okay, fine. So what was I saying? So I was saying, so if you are pregnant, if you find that you are pregnant, your test is positive, your pregnancy test is positive, maybe you do a home test and it's positive, even if you don't see a big abdomen, go to the clinic, then you will be offered HIV tests there. So whenever you come on your first visit, whenever that is, you will be done HIV, you will be offered HIV test. If it's negative, you will continue throughout your pregnancy. Throughout every time you come for your ANC, you will be done HIV test. Even the day you are delivering, you will be done the HIV. We are going to talk about intrapartum, like during the delivery. We are going to talk about that, but you will be tested. If it happens that they test you on that visit and it's positive, it goes back to this: start ART or ARVs, take the blood, take the CD4, do the VL, it's time for the VL, and rule out other co-infections and that kind of a thing. You continue with your treatment. So Okay, because of time, guys, it's already 24 minutes now. We're gonna do part 2 where we're gonna be talking about this and the other parts of the PMTCT. Thank you so much for watching.